So tell me what your relationship is like at Columbia with radiation oncology, looking at SBRT versus ablation for either oligometastatic disease or small primary liver tumors. How do you guys work through those?
Yeah, so with RadOnc, we have a pretty good relationship, and I think there is this understanding that there are certain tumors that are going to be challenging for us, right? Whether it's location for an ablation, whether it's too central, or it's just in a really tough spot, super high up at the dome, and there's no vascular supply. It doesn't happen that often, but there are those tumors. They're we have a very good relationship with them where if it comes to it and we feel like, okay, we probably would be, not by we, sorry, the patient would probably be better off with RadOnc, like we're happy to send them to, our radiation oncology, colleagues. Like I said before, with the liver, there's so many treatment options that I do think that there is a role for radiation oncology. I think that there are certain tumors, whether it's, hypovascular or there's, extra hepatic supply to the tumor. Sometimes that can be challenging. Or it's something that we've kind of already hit with everything. And we're like, all right, well, we need some help. So maybe radiation onc can help. Those are kind of some of the patients that we'll send over to radiation oncology. And they're very happy with kind of helping us, with where they can. I understand that may not be the case across the country, but I think that we've got a nice setup where we have a bit of an understanding with them, and it's every patient by every patient,
Yeah, I know. I mean, in my tumor board, the radiation oncologist tends to say for every patient we present, like, yes, we can radiate. And sometimes we have to say, slow down.
I know, and I think the data doesn't suggest that, right? It's like ablation is superior to it, but they're in tumor board, and for the most part, I will say the RadOnc folks, they don't say too much except for when there is a role for it. But every once in a while, there will be somebody who's like, oh yeah, we can SBRT that, and a lot of times us and the surgeons will be like, okay, yeah, we could potentially do that, but they end up coming to us for an ablation or a Y90,
So I'm having a lot of these conversations with the surgeons at tumor board because I work with a group of very skilled and frankly, pretty aggressive hepatobiliary surgeons. And they actually try to do a lot of the ablations on their own. Big fans of robotics. They do intraoperative ablations. And when we're looking at those, a lot of what it comes down to is, can they see the lesions? And if they can't, the next question is, can I see the lesions, either with ultrasound or CT? And that's kind of how we determine who treats it. And I think the data supports this for intraoperative ablation. I mean, they're going to be more comfortable going after larger tumors than I typically am.
Yeah. Oh yeah, for sure. Yeah. And with direct visualization, that's, I hate to say it, but like, if you're seeing it right there, like you can do it. It's funny, actually. So a couple of my surgery colleagues have actually done that. And there've been a couple of times where they've actually called us down to the OR and been like, yeah. And they're like, hey, do you want to help us out with this? And we're like, me or one of my colleagues will be like, sure, let's do it, Yeah. So it's, I think a lot of it is relationship building too, and I'm sure you can attest to this as well. It's like in the beginning when nobody knows you or anything, like it's, the advice that I always give to kind of my junior colleagues is like your first 3 to 6 months, just listen, observe, like, even in terms of cases, just do bread and butter cases, get your feet wet and everything. And then when you get into the flow of things and like, you can kind of see like, okay, how does this work, right? Like who are kind of the major players here, right? Now you can start to offer up certain things. And a lot of times what I've noticed in tumor board is sometimes, whether it's the hepatologist or the oncologist or even the surgeons will sometimes just not realize that like, oh, this is an option. Like whether it's ablation or Y90, because everybody is just thinking in their own silo, right? Like we're thinking ablation, Y90, like all the IR stuff, right? The surgeons are thinking surgery, oncs are thinking systemic, but like until someone says like, oh, hey, like what do you think about ablation here? They may not even think of it. And then when they think of it, they're like, oh yeah, that's an interesting thought. Yeah, that's a great idea,
Absolutely. Asad, are you guys doing any combined embolization and ablation cases?
Yeah, so it's our setup is kind of interesting. We actually have an outpatient office as well. So a lot of times what we'll do is do like a taste ablation kind of thing where where we'll taste like in the office or sometimes even at the hospital, and then you leave your Lipiodol there, and you've got your target now, and then you just come back and you ablate. So I think that the combination of that is it's really pretty effective, especially for places. I know there are places around the country where, now I was trained mostly Y90 and ablation, right? I did like a handful of TACEs. I did some when I got to Columbia, but I think a lot of training is kind of going that way. I still think there is a role for kind of TACE ablation in certain patients. Like I think that that's the way to go. It's funny though, because like there's a little bit of a dogmatic Y90 ablation, but like we also kind of have to think a little bit outside the box sometimes with certain patients and certain tumors.